Good evening. My name is Paul Lorenc. I am an aesthetic plastic surgeon right here in New York City, and welcome to tonight's webinar. My assignment is to speak about the aesthetic facial anatomy and its implications in so many different things when we treat patients, not only millennial patients, but all patients. And also I'll get into a little bit of the anatomical differences between the sexes, and I think that's an important part of what we do. So these are my disclosures. So as was mentioned before, millennials are really patients born between 81 and 96. It's the largest generation right now, so they have huge purchasing power, 75 million. It's important, obviously, it's important in our practices. I've been in practice here in New York City for a little bit over 20 years, and I have to tell you, my practice has changed tremendously. The character of my practice has changed tremendously. And the reason for that is that millennials have become very, very important, and even younger patients. I also have a 23-year-old daughter that just totally drives me crazy with all the questions that pertain to beautification or prejuvenation. But that's what the younger patients are doing, and that's what they are focusing on. So as far as the millennial patients, I think age-related changes are very different. So aging starts from the day that you're born, obviously. But we see changes in the anatomical sort of component, which translates into the choice of fillers or toxins that we're using and the applications of the products that we are using. So I think anatomy plays a very, very important role in how we choose the products and how we inject them. So social media, obviously, of paramount importance. It shapes really their being, so to speak. Younger patients, millennials, are much more comfortable with maintenance versus 20 years ago when I went into practice. It was a patient visit that happened in the age of 55 to 60, one-time procedure, and they're done. And then you would sort of see the patient once in the practice. Obviously, it's very different. It's about maintenance, not radical changes. There are also changes in really the character of the patient that we're seeing. So it's multi-ethnic. 50% of millennials are white, so fewer Caucasians. And another thing that I really pay, and I think we should pay attention to, obviously, we pay attention in my practice, it's really that the patients, it's 12% of our patients identify themselves as transgender. And I think that's very important in choosing this sort of application, whether it's fillers, toxins, or even surgery, based on the sort of the norms that we have formulated 20 years ago, really what the ideal male patient should look like, or what the ideal female patient should look like. I think that's an old concept, and I think we really have to get away from that concept because it is a fluid situation, and sometimes applying different concepts to whether a male or a female patient is the right thing to do. So please keep in mind that 12% of our patients are really transgender or gender non-conforming, and I think that plays a big role in choosing the procedures and choosing what we're going to suggest to them. So the rule of proportions, these rules were really made or created many years ago, 20 years ago. So the definition of masculine and feminine. The data was originally harvested or really gotten from Caucasian patients. And obviously the makeup of our practices have changed tremendously. And I think we have to think out of the box when it comes to that. I think we have to disrupt this sort of underlying male versus female type of structure because I think it's healthy for the patient and it really assures a happier patient at the end. And I think treatment should be very much individualized. And here you see even the perception that Picasso had of himself. It's an autoportrait. First on the upper left-hand corner, it's at 19, and then at the age of 90. And you can see how it's really fluid. His perception of his image is very fluid, and it changes. And I hope that we can embrace that and incorporate it into our practices. So again, we've learned a lot about anatomy. Anatomy is one of my favorite topics. I mean, I love anatomy because it really drives what I do, not only surgically, but also non-surgically. And even a simple understanding of what we call a direct and indirect effect. When you inject laterally in the temple, you have the direct effect and the indirect effect. When you inject the malar eminence, you have the direct, and we're actually doing a number of studies on this, you have the direct effect of volumizing the malar eminence, but you also have the indirect effect on the nasolabial fold. So we've incorporated our knowledge of anatomy, how to inject, and we'll get a little bit later on into the role of retaining ligaments, which I think they do play a role in how we distribute and how we administer fillers. So again, you have to understand the variations in the individual anatomy from patient to patient, but also from younger patients to older patients or vice versa, and you have to incorporate that. I typically, I will mark everybody preoperative, pre-injection, whether it's toxin or filler sitting up in an upright position. I think it's key. I think you have to individualize it. And I think it assures a success much more likely than just using a standardized, let's say, injection grid. So we have different tools. We are obviously using energy-based devices. It's a multimodal approach. It's multifactorial. It's so many different devices. It almost seems like there's a new device or a new filler on a monthly basis. But we incorporate them, and it has to be based, again, on anatomy, because ultimately that really is what determines the success. So the treatment should be individualized. I think that we cannot sort of pigeonhole patients into our stereotypical sort of proportion of ideal male and ideal female. I think that should be thrown out the window because identity really is fluid. And I think that making these assumptions is counterproductive. Obviously, communicate that with your patients and continue learning as you're doing tonight, taking a webinar such as this. So anatomy is key. I think everything we do is really based on anatomy. And I always think in terms of sort of marrying the physiochemical properties, let's say about fillers, marrying the physiochemical properties of injectables versus anatomy. And really that assures you a good result, because if you pick the wrong filler, let's say with the wrong G prime in a high G prime in a very mobile area such as the lip, you will not have a good result. And vice versa, if you take a filler that has a very low viscosity, low G prime, and you're trying to lift either the temple or the malar eminence, you will not have a good result. So anatomy is key. Again, safety is first. We've incorporated ultrasound into our practices, and I'm sure most of you have as well. I think that, again, it's good for the patient. Understand the placement. We already talked about all of this, achieving natural results. And I think, we have to get away from the stereotypical male versus female. I think we have to understand ethnic variability and the fluidity really that we see in our patients already. So as you can see, this is a very complicated area, and this is I think this is a very cool representation of the layers that we have in the face, and you see how complex it is. And I think it's very important to understand and know anatomy. And I'm not just talking about vascular anatomy, because I think we all know that, but also the sort of the three-dimensional anatomy, because that's what we have to pay attention to. So it's not only the musculature, which we'll talk about in a little bit when it comes to toxin use, but the vascular anatomy, obviously, which I'm not going to touch on during this lecture, but really the spatial anatomy and what happens volumetrically, both in younger patients and the difference between the sexes. And I think that's something that you have to keep in mind whenever you're treating a patient and whenever you're choosing a particular product. Because if you don't do that, you're not going to have a good effect. So the effect of age, obviously, the signs of aging are predictable. Changes in the skin, the ligaments, the fat, the bone. But really the most important part that we've come to understand is the deflation of the face. And a lot of the work has been done by Joel Pessa and Rod Rohrich on really the deflation of the deep fat compartments, which plays such a big role. But to me, in my mind, that's not the only importance. Obviously, the importance of bony resorption. And we're beginning to understand that more and more. And there are differences, obviously, between the sexes, but there are also differences in the aging pattern and when it starts in men versus women. So there is the change in the facial shape, obviously. Age-related shape changes it's similar in both sexes until about 50. And obviously that's around menopause where you have this very significant resorption of the midfacial bone. And the changes are both in the mandible, in the periorbital area, and certainly, and most importantly, in the midface, where you have this internal rotation of the facial skeleton and you have loss of volume, which has a tremendous effect, not only on the volume of the face, but also on the surrounding tissues, and as translated through the retaining ligaments on the skin, where you have descent of the deflation of the deep compartments, descent of the superficial compartments, and descent of the skin, showing obviously manifesting itself as the aging process. And this is just to sort of differentiate the areas that bony support, that the changes that happen. And most of the resorption and most of the changes in younger patients and millennials are really isolated to the inferolateral orbital rim, which is pointed on the right side, the maxilla, and of course the prejowl area of the mandible. And those are the most areas that I see in my practice where I see millennial patients coming in. So it's the tear trough injection, for instance. It's the piriform injection, and also the jawline. The jawline, we can spend an hour talking about the jawline and the differences, and I'll get to that in a second. But there are tremendous differences and changes in the aging pattern of the jawline, whether it's the chin point projection or the mandibular angle. And all that plays into the difference between male and female, but also the differences in aging and younger patients versus older patients. So again, in younger patients and millennials, it's mostly the inferolateral orbital rim, the maxilla, including the piriform, and the prejowl area of the mandible. So the differences between female and males, you can see that the forehead is more rounded in women, smoother supraorbital ridge, round orbits in men. The orbit tends to be a little bit more square, sharper upper eyelid margin, pointed chin. In men, more square, the chin is square. And obviously, now I'll get to that in a second, the angle of the mandible, of the ramus, is very, very different in women. And it's different versus men. And I think it's very important to understand the anatomical differences, because you don't want to necessarily masculinize a woman or vice versa. And all of that is related to understanding the anatomy, understanding the proportions, and really even the angle of the ascending ramus versus the body of the mandible, because that changes as we age. So those factors are very, very important to keep in mind. And this is an example exactly of what I was talking about. It's called the L to I phenomenon in women. And you can see how the mandibular angle changes. On the left, you have a 22-year-old patient. On the right, the same patient at the age of 70. And you see that the angle of the ascending ramus versus the mandibular body opens up. So it becomes really from L to an I, and the projection changes, and the mandibular support changes. So, and the volumetric changes occur, and you have to keep that in mind. So again, it's not only the volume that changes, but even the angularity of the mandibular angle. And there's also a difference between men and women, and you can see to restore that youth or rejuvenate someone, let's say in their 30s, you really want to go back to that more of an L type of shape of the mandibular angle. And there's a difference between men and women. The mandibular angle, the ascending ramus, in men is more posterior to the axis of the ear, or at the axis of the ear. In women, it is anterior. So for instance, if you take someone that you want to make or masculinize, or you want to take a man where there has been bony resorption, the injection is most posterior for the mandible. and to bring it in more into the proportion. You can certainly do that in a woman. And recently I had a patient that wanted that. She wanted more of a definition of the angle of the mandible. And actually she was beautiful before, and she was even more beautiful. But I used this concept that get away from this sort of standardization of our preconceived notion of what a perfect male versus perfect female proportion is. I think that's passé. I think that we have to incorporate this sort of fluidity and this ability to interchange and adapt it specifically and individually to each patient. So the role of retaining ligaments, again, this is a concept that I think is valid. There's obviously new data now even on the role of retaining ligaments in the buttock as far as buttock augmentation. But what we're doing is basically using the ligaments that are firmly adhered to the periosteum to lift the surrounding tissue. Perfect example, and as you know, that retaining ligaments are binding the soft tissues of the face together. They define the shadows and the creases of facial aging, because obviously what they prevent is they prevent descent of the soft tissue, but anything anterior or posterior to it can descend. So they serve a very important role, but we can use them to our advantage in order to maximize really what we're trying to do. For instance, in the lid cheek junction, perfect example of utilizing that ligament where you inject that and you use that ligamentous support to decrease that sharp transition between the lid and the cheek by injecting right around the ligament. So that's one concept. The other concept is obviously the mandibular, platysma mandibular ligament, where that's really defines where the jaw, the prejawal sulcus is, because everything is adherent. So obviously the injection has to be anterior to it instead of posterior in order to rejuvenate it. And I think the concept of using retaining ligaments to our advantage, it's certainly valid. And I think it's important to keep in mind where the ligaments are, because you can, this concept is not necessarily very new. We've used this concept and we use it every day surgically. We've also used it in sort of minimally invasive procedures such as silhouette, where the concept of using that ligament to lift the surrounding tissue is valid. But now with volumizing agents, and certainly with products that have a high G prime, that are viscous and stay in place, I think that's a very valid concept. So keep in mind the ligaments that we have and we can use to our advantage, and as we using it in rejuvenation. So with age and really these changes, so the changes in bony resorption really start actually in the late 20s, 30s. And you can see that in the millennial patients. Again, it's mostly in the periorbital area, in the piriform and the mandible. As far as fat, as we know, there are really the deep compartments and the superficial compartments. The deep compartments really atrophy or deflate. I like to think in terms of deflation more than atrophy. And the superficial compartments, they either reposition, they sort of slide, or hypertrophy. And obviously the mimetic muscles, or SMAS, is in between the two layers. Now, one thing that I do want to mention is that specifically when it comes to piriform, and which is, if you think about it, it's really the injection of the deep medial cheek fat cells, which is right. You can see it right here, and to me, that's the most cost-efficient injection if you think about it, whether it's a millennial patient or an older patient. If you have 1 cc of product to inject, by injecting in the piriform, you cause the biggest change. And the reason for that is that it translates not only into the piriform, the loss of volume, to correct that, but it also has an effect on the tear trough, just because of this concept of direct and indirect changes. So as far as, again, more fat, and this is just as far as changes in the fat and the resorption of the fat, or specifically when it pertains to millennial patients. So the most commonly impacted fat in the millennial patient is first in the infraorbital hollow, so the periorbital, the nasolabial fold, and in the jawline. And here's a schematic on the right side, just showing the resorption of fat, or the changes in fat, from first to last. And again, it's mostly periorbital. nasolabial fold, and jawline. And that's why injections, understanding that in the millennial patient, that's the more common area, that's where we're going to be injecting fillers most often than not. As far as muscles, I think, again, another hour lecture on muscles, but the point is that the muscle is, and my latest interest is in the platysma, because I think it's a fascinating concept of sort of unloading the downward forces of the platysma and the DAO as far as realigning or rejuvenating, or whether it's a millennial or an older patient, the mandibular border, because just by doing that, by denervating the platysma and the DAO, you can really redefine the mandibular border. And as I mentioned, in the millennial patient, that's one of the most common concerns that they have. It's not only the fact that I want more chin projection, but it's also the fact I want more of a defined mandibular border. And using neurotoxins is absolutely a perfect way of doing that. Unfortunately, it lasts for about 3 to 4 months, but I think it's a very good non-invasive way of doing that. So again, platysma is my favorite muscle right now, but obviously we're affecting all of those muscles. So the muscles do atrophy with age, but because of the changes in the skin, they manifest themselves more in the aged patient. And you can see just even the periorbital or crow's feet, how in an elderly or older patient, it's manifested so much more just because of the quality of the skin, the thickness of the skin, and really the loss of the subcutaneous tissue, which happens as we age. But we see that also in millennials. I mean, it's not uncommon that one of the most common injections for toxins, obviously, is crow's feet. I have been lately probably the most commonly asked for injection by younger patients in my practice is just to do the lip flip with the toxin, or just 4-point injection. It's probably the easiest thing to do, and it really gives a very, very nice result. Unfortunately, it's short-lived because we can't denervate the orbicularis, or you lose the competency of the muscle. So these are the muscles that obviously we use and we moderate or modulate using toxins. And I think that's an important concept to keep in mind, that specifically, whether it's millennials or even younger patients, they don't want radical changes. They want maintenance. They want to modulate it. For instance, when you work with the frontalis, it's very common. We all get requests to just reshape my eyebrow. And it's very easy to do. I typically combine injection, obviously, of the glabellar complex and central frontalis with the lateral orbicularis to elevate the lateral brow. And you can reshape the brow, being very specific in applying toxins. I think it's important also, just an aside, I tend to concentrate my toxin even more when I'm working in the lateral orbicularis, just to make sure that there's no diffusion into the levator. But these are all the muscles. Most commonly right now, younger patients tend to ask for brow repositioning or brow shaping, so to speak, and also for just eversion of the upper lip, which is very easily done. Typically, I use neurotoxins such as, let's say, whether it's Botox or Xeomin or Jeuveau or Dysport, and I typically use 4 units for the upper lip, 1 unit times 4 injection points. There is variability in all musculature, and this is an example of tremendous variability of the frontalis muscle, its insertion, its crossover, and really the effect that injecting or modulating the muscle will have. So what's important, and this I strongly believe that each patient has to be individualized, and whether they're a millennial or an older individual. You can see the tremendous difference here. If you use a standardized pattern of injection for the frontalis or the glabella, so it might not be enough on the patient on the left, and it might be totally misappropriated on the patient on the right, whether there was really no activity of the frontalis. If you think about it, very limited activity of the frontalis, and the patient second from the right, the frontalis is only central. So it would be completely ineffective for that patient to inject the lateral brow, because it's not going to work. It's just a waste of the toxin. So individualize it, and the way to do it with, and again, in younger patients, exactly the same approach is to mark the patient in a dynamic sort of status, sitting upright. Same thing with the glabella, with Procerus and the corrugator. Again, different patterns, as you can see right here. I identify them, I mark them in an upright position, and I think that makes the injection much more efficient. And it's just better for the patient, because obviously if you're using 25 units and you're using only half of it in an area that has neuromuscular junctions, you're just wasting the product. So a little bit of differences in male versus females. Obviously, men typically have a higher muscle mass, and this is based on work by Corey Moss. You have to adjust that, especially in the Procerus and the corrugator area. I think there are differences between men and women. Again, mentalis, DAO, and the depressive DLI are smaller in women, and you have to adjust the dose. Zygomaticus and frontalis muscles are larger in women. So again, you have to adjust the dose. You have to adjust also the dose in younger patients, in millennials, because typically the muscle is not overactive, and you have to, again, adjust the dose. Typically, it's a smaller dose that I administer in a younger patient. Just, again, try to individualize it and based on each marking. So as you know, the changes in the skin are very, very important, whether it's millennials or younger patients. We lose the protective mechanism. Again, I won't get into the collagen loss and elastin, because that's all self-evident. So the timeline of aging events, and I think this is probably one of the most important slides. So in the 20s, my daughter's age, beautification. It's about beautification. I want to look beautiful. It's about asymmetry. It's about correcting asymmetry and dynamic lines. And some of them are already around the periorbital area. But that's just the beginning. And I'm seeing patients in the 20s already. In the 30s, it extends into the forehead, glabella, the canthal lines. The eyebrows descend, so you can certainly do a chemical brow lift using toxins. The fine lines around the lower eyelids. Tear trough, not uncommon for millennials to come in asking for correction of the tear trough. And I think that's I typically use a supraperiosteal injection. I think it's just a more anatomically sound injection for correction of the infraorbital or of the tear trough. Mid-face begins to age. Again, you will have patients, millennials, asking for injection of the piriform. We stop chasing lines. I mean, there's tremendous change, obviously, in the way that we think, and that's all based on our anatomical understanding and understanding anatomically what happens. And so we place it. In the 40s, obviously, dynamic lines deepen, more role for neurotoxins. Tear trough elongates. I mean, you can read all of the things. The jawline loses definition. A little bit about the jawline, because I see younger patients, millennials, typically coming in for definition of the jawline. Very different for men versus women, but it's very common for patients to ask, I want a well-defined jawline, I want a well-defined mandibular angle, and I want more chin projection. And luckily, we have all of the modalities. So now we have many modalities. Between the use of neuromodulators and fillers, you can really, and I believe, and as a plastic surgeon, I hate to say this, but I think we're very close to a surgical result as far as redefining the jawline using a combination of toxins, fillers, and obviously energy-based devices. So in the 50s, again, it's just a progression of that. Now it's more of mid-face structures. It's more about deflation of the mid-face and correcting that based on our anatomical knowledge. And in the 60s, it's over. No, I'm just kidding. In the 60s, you just begin to live, actually. But all of the other aging aspects are brought into view, and again, using your knowledge of anatomy and matching the physiochemical properties to that area. So as far as millennial patients, they don't like looking tired. They don't like looking older. So toxins for dynamic lines and brow position, improvement of the nasolabial fold, as I mentioned. My daughter has this in her age group, the snatch jaw, which means just well-defined, pointed jaw. That's what they're looking for. Lip augmentation, obviously, as mentioned before. Lip flip, very, very common. Liquid rhinoplasty, I don't like the term, but it's an injectable to the radix, and you can use it to the columella. You can also enhance even the lower lateral cartilages. And obviously, we see patients in millennials for skin quality issues and hair restoration. So in conclusion, treatment should be individualized based on patient needs and desires. Again, think out of the box. It's a fluid situation. We're not just male, female. I think we have to think in a very different way. Take time to understand the anatomy and impact on aging. I think that's key. And also be adaptable and willing to take into account individual identity. I think that's key. And keep learning about new developments and approaches and stay current. I think that is certainly the most important thing. And I want to thank you. And now I'll turn it over back to the organizers.